Hi, this is Dr. Chan from Isaac. Today we'll be talking about rising above a bad situation. This is an interesting case of a 50-year-old Chinese businessman who has mild cataract on both eyes. His vision was 6/9 on both eyes. He wishes to be spectacle-free and hence opted for a trifocal lens implant. It was planned for a trifocal toric lens. This was seemingly an uneventful case. In the beginning of the surgery, I did a hydrodissection and hydrodelineation and removed the lens without any problem. In an immature cataract, it is easier if hydrodelineation is done to pop the lens up so that phacoemulsification can be done easily. All that is needed is just to maintain the phaco probe in the middle and gently phaco the remaining nuclear material away. I would remove the remaining cortical matter away by sweeping the IA probe in a large area to remove a large chunk of cortical matter, instead of taking tiny bits chunk by chunk. At this point, all the cortical matter were removed. I inject the viscoelastic to prepare for lens insertion. And this is where the nightmare begins. The Rycoff from the viscoelastic was not well secured, hence it plunges into the posterior capsule, causes a PC rent. I was in shock. The patient had good vision pre-operatively. What should I do now? At this point, I checked for any injury and the extent of the PC rent. I've noticed that the PC rent is only at the 7 o'clock of the surgeon's view, which is depicted on the picture below. My plan is to convert this into a posterior curvilinear capsulotomy. I injected viscoelastic to tamponate the vitreous that may be prolapsing from the PC rent area. Remember not to over-inject viscoelastic as it may cause an extension to the PC rent in an uncontrolled fashion. I use a standard Utrata to extend my PC rent into a standard posterior CCC. It is inevitable that some of the vitreous may be pulled out into the anterior chamber while you pull out the posterior capsule. Hence, you need to inject viscoelastic to tamponade the vitreous back into the posterior chamber. As things looks pretty stable, I have decided to use the intended trifocal toric lens to put in the bag as planned. This is a Zeiss AT LISA trifocal lens, which is a plate haptic. Once inserted, it can be turned both clockwise and anti-clockwise. I inserted the leading haptic into the bag first, and the trailing haptic remains in the AC. The trailing haptics are then gently nudged into the bag by using a lens dialer. The lens is then dialed into position of the intended axis. However, there is no marking shown on this video as the surgeon is using a digital marker. The capsular bag felt stable. However, we still need to take care not to overstretch the capsular bag. We also need to make sure that there is no vitreous in the anterior chamber during this maneuver. Once the lens is in position, I remove the remaining viscoelastic with Simcoe. This is to make sure that I have a better control of the anterior chamber pressure and to make sure I do not pull the vitreous along. At the end of the Simcoe, I injected the patient with Myostatin to constrict the pupil and look for any vitreous. I did notice there was some vitreous in the peripupillary area, hence I have injected some triamcinolone to view the vitreous in the AC. I then performed anterior vitrectomy, removing all the remaining vitreous in the AC. As the wound was not extended, I did a stromohydration and closed the wound and remained it sutureless. The patient's vision was 6/9 the next day post-operatively. The patient proceeded with his fellow eye operation a week after. This was the patient's post-operative refractive result in 1 month, which was almost emmetrope. His unaided vision was 6/6 distance and N5 near. This is the picture of the patient 1 month post-operatively. The lens remained well-centered and stable. Here are some take-home messages. Always check your instrument every step of your way. Do not panic and think fast. Overcome your fear. Thank you very much. Hope this benefits.